Good afternoon to everyone joining our webinar. This is Tracy Klein. I'm chair of the Reinhardt Healthcare Law Department. We're really proud today to present our team and today's speakers. As most of you know, Reinhardt has one of the largest and maybe oldest healthcare law practices in the Midwest. We always used to say we had 150 years of combined experience, but we didn't want anyone to think we had old lawyers. We have also many young lawyers and very many vibrant practices. So you probably know us, but what you probably don't know about us is the breadth of our practice. It's really unusual that we have lawyers who specialize in long-term care, assisted living, also hospital and health system, physician practice work as well. And then what is little known, I think, out of certain circles is that we have one of the largest nationally recognized hospice healthcare practices in the nation. And we recognize as time has developed, as the healthcare industry has evolved, and with the Affordable Care Act, that many of our health system clients have become not just horizontally integrated, but also vertically integrated. You know, the consolidations and affiliations that have affected all of our organizations have been profound over the last 5 to 10 years. So what we thought we would do within our own healthcare department, we talked about the fact that we have expertise that we can share with different segments of the health industry. And so today what we wanted to do was showcase and highlight for you hospice compliance issues and hospice risk management issues. So what we will do today is run through a primer, and Carla Hutton-Pinkerton will be leading the charge in terms of that material. And I've asked Heather Fields, who many of you know, to join as moderator and to provide her special insights. For those of you who don't know Heather, Heather is the chair of our hospital and health systems practice, and she's practiced in the healthcare area for more than 20 years. She is not just a hospital lawyer or health system lawyer in our practice, she's also our specialty expert and really provides deep specialty advice across all of our subgroups and specialty areas. And what I'd like to say about Heather is she really practices at the top of her license. You know, she keeps abreast of all the developments in many, many areas on behalf of the group. One of the areas that she's particularly expert in is compliance. And she is also a member of our corporate compliance and white collar litigation group, as well as the hospice and palliative care group, which you're going to hear from today. Heather and I are also very pleased today to present Carla Hutton-Pinkerton. She is one of our senior lawyers in Reinhardt's healthcare practice, where she works primarily with the hospice and palliative care group. So she has been working for more than 5 years, almost exclusively in the hospice world. She frequently works with hospices in evaluating all their compliance issues and all their risk management issues. So we've enlisted Carla to explain, for the benefit of our health system clients and others on the phone, the world that she is so intimately familiar with and nationally known in. With that, I'm going to turn it over to Heather, who will give us a roadmap for today's presentation.
Thanks so much, Tracy, for that gracious introduction. I'm really excited today to have Carla present to you. She has a wealth of knowledge on hospices, and we are not going to disappoint. I think that what I find in working with large hospital health systems is that oftentimes hospice may or may not be seen as a really significant area of risk for the overall organization. Might be that it just represents or reflects a smaller percentage of revenues overall for the health system, and that risk is attributed on the basis of that revenue generation. Sometimes it's just a knowledge gap. And so what I can promise you is that by the end of the presentation today, you're going to have a really good understanding of some of the unique aspects of hospice and hospice risks. And I am very pleased to turn it over. Well, let me just walk through some of the key things. We want to talk about what's going on in the hospice industry. Lots is changing, but some of the key risk areas will be touched on as well, the trees, so to speak, the coverage requirements, aspects of how determinations are made as to what is covered under the hospice benefits. As you know, when someone elects to have hospice, they are deciding only to receive hospice benefits, and all services related to the terminal illness are going to be covered under that hospice benefit. We also want you to be really sensitive to what's going on in terms of the government's data analysis efforts, as well as why and how hospice is a real focus for False Claims Act litigation presently. And then Carla will turn it back over to me to give you just a couple of next steps that you can take back to your organization in terms of what you might do to better manage these risks. So without further ado, I'm going to turn it over to Carla.
Great. Thank you, Heather, and thank you, Tracy, for that wonderful introduction. I'm really excited to be with you guys here today and kind of give you some background in the hospice world that I work within on a daily basis and try to make some connections for you and provide some additional information that Heather will pull together at the end. But before we can really delve into those trees that Heather mentioned, the first thing we want to touch base on is the current landscape that hospices are operating in. It's really important to have this general idea of the factors that influence these overarching issues and risk areas that we're going to really delve into later. So the biggest thing, and this may or may not be surprising to you, but hospice has grown incredibly. From 2000 to 2012, Medicare expenditures in hospice has more than quadrupled. It's now a billion-dollar industry in terms of Medicare expenditures. I'm not going to kind of read all of these micro statistical points, but really the big piece is that while this growth has begun to level out, the damage per se or the influence of that growth is continuing to impact how hospices are operating. And it's really prompted a lot of change, not only on the regulatory side of things, but how hospices are having to respond to that. Perhaps the biggest or the most visible change, I would say, is the regulatory changes since 2008. And nearly every year since then, hospices have had to respond to a variety of regulatory changes. And 2008 was the really big overhaul of the conditions of participation. That made an impact on contracts, which Heather will touch on later, but a really, really important piece for hospices. And since then, most of the changes, I would say, are focused on really improving and requiring that physician involvement. And these are touching on conditions of payment. And we'll kind of needle into that later, but really the big point there is these are requirements that hospices must meet in terms of being able to be paid by Medicare. And they really end up being low-hanging fruit for auditors, repayment issues, and other issues or risk areas that we're going to go into in more detail. And with these, with hand in hand with the growth and the regulatory changes, we've seen an increase in not only audits but also False Claims Act cases. From the audit side of things, it's primarily zone program integrity contractor audits and Medicaid integrity contractor audits. These differ somewhat significantly, but their outcomes in terms of dollar values for hospices can be quite significant. They're primarily focusing on long length of stay, GIP or general inpatient care, and they've also shifted to doing quite a bit of on-site reviews. And then on the kind of the fraud case side of things, we're seeing criminal indictments. In 2015, there were at least 9 hospice-specific False Claims Act cases, and these settlements are getting into the millions right now. And so really the big takeaway is that with all the growth that the hospice industry has seen, it has truly put them on the radar in terms of where the government sees them fitting into this larger healthcare puzzle. So we would probably, in the general scheme of things, consider this to be on the less impactful side of things, but there has been a rise of surveys. This goes hand in hand with hospices being on that radar. They used to really not have a survey impact in the sense that hospices could go 7, 8 years without having a state or accreditation survey. That has shifted, and with the Impact Act, hospices are now on that somewhat regular schedule of every 3 years having a survey occur. And while this is focused on those conditions of participation, it can have outcomes in terms of Medicare certification and enrollment. Another large piece of this background is government data analysis. Hospices are required to report so much on their claims, and what we are seeing with that is that the government is analyzing that data, they're pulling it together, and they are really finding areas outside of the traditional hospice nursing facility relationship to shift their focus to. Back in 2009, that was the main area. They were primarily focused on the fact that 82% of hospice claims for beneficiaries in nursing facilities did not meet those conditions of payment. While that is still an area of concern, they are shifting well beyond that. In 2012, they were looking at relatedness issues with Medicare paying essentially twice for prescription drugs, paying the hospice and also paying pharmacies through Part D. In 2013, they started to focus in on general inpatient care and the utilization of that higher paid level of care. This has been followed up more recently with a another report in 2016 on GIP, or general inpatient care, where they're finding that nearly 1/3 of all GIP stays were billed inappropriately. And then most recently in September of this year, really scrutinizing the whether hospices are meeting their election requirements. And as most of you know, that hospice election is truly the threshold to payment. If the government were to find, or an auditor were to find that election to be invalid, they could potentially use that as a reason to not pay any of the care that has been provided under that patient's election. And in terms of data collection, it goes beyond what we're seeing in, with these OIG, or Office of Inspector General reports. We're also seeing them get down to the hospice-specific level. And when I say specific, I mean like your actual hospice name. They're pulling these, what they call PEPR reports, and that lets you know how your hospice compares to both state and kind of regional national data. They also have what we refer to as the App Associates report, and this is back in 2014. It was really a watershed report in terms of the type of data it captured about hospices, and ultimately that data ended up having a very large impact on the payment reform that we saw implemented back in January. Some of the items, and we'll discuss in more detail, but some of the items they drew out in that report are what essentially convinced regulators to move forward with a significant payment reform that changed how hospices are paid, both at the beginning and end of a patient's time with hospice. So where's the hospice industry going? I would say that scrutiny is going to continue, and it's going to continue for quite some time. As I mentioned earlier, there's quite a bit of low-hanging fruit for the government auditors in terms of where they can pinpoint hospice issues. There's also this payment reform has yet to really play out. It's implemented in this past January. There could be more payment reform in the future. There could also be additional audit focuses directly on that payment and how hospices have responded to it. Likely we'll continue to see regulatory changes as they try to figure out how to mesh these election and certification requirements. But really the overarching point is that hospice is here to stay, so we have to find a way to not only survive but really thrive in this heavily scrutinized industry. Now we're going to take some time and focus in on what we've referred to as the trees, but really those risk areas and issues that hospices need to have on their radar. Heather mentioned them before, so I'm just going to go through them quickly, but it's really these coverage requirements, or what we call the conditions of payment. Relatedness determinations, I think, are especially important with hospital-based hospices, as there's that potential for overlap, potential for someone to bill Medicare Part B instead of Medicare Part A. There's this bigger picture of claims data and government data analysis, the trends in hospice audits and where we're seeing those go, and then this rise in the False Claims Act, anti-kickback, and whistleblower allegations, and ultimately the cases coming out of there. So to start the coverage requirements, this is a bit of a 101, but I think it's a really important place because this is where hospices kind of at their core need to be well educated, well run, well operated in terms of being able to make sure these are met and be appropriate for payment on a daily basis. We find in working with our clients that sometimes managers, directors, or even the clinical personnel are not well aware of what these coverage requirements are. It can lead to significant compliance issues. We also, as I noted earlier, OIG has found that in some cases 82% of hospice claims for beneficiaries, especially those in nursing homes, were not meeting one or more of these coverage requirements. We've spelled these out quite simply on handout 1. We laid them out. It's important to note that there are cross-references to a couple other very specific regulations. One of those cross-references is to the election requirements at 418.24. Another cross-reference is to the certification requirements at 418.22. I would say those are the most critical or the most important in terms of those low-hanging fruit. There's many, many technical requirements that need to be met there. There's also cross-references to 418.56. That's the plan of care, and another area that we've really seen an uptake in terms of audit denials related to that condition of payment. You'll also notice on the handout 1 that we do identify those conditions of payment for Medicaid payment of nursing home room and board. I'm not going to get into that nuance today, but I did want to point out that it's kind of helpfully combined there on this handout 1 for you guys. The important thing here is that there are these 4 different levels of care. The conditions of payment are kind of the base threshold, and then each of those levels of care does have kind of a +1 essentially. Routine home care is that most common basic level of care. Then we have the general inpatient care that's most likely going to be seen in the hospital setting or in the skilled nursing facility setting. There's, as you've seen with those Office of Inspector General reports, a lot of scrutiny there. Patients do need to have a level of pain or acute or chronic symptom management that cannot be achieved in their home setting. We also have respite care. There's a 5-day limit on that. That's not something we typically see in the hospital setting. It's more common in that nursing facility setting. And then continuous care, which I would say is probably the least common in terms of it has a significantly higher standard in terms of meeting these very micro-hour requirements. It needs to be predominantly nursing, which is more than half, and it is that highest paid level of care. The ramifications, as we've sort of gone over, is this, they are the conditions of payment, so not meeting them would mean that, on a pre-payment review, the hospice would not be paid. On a post-payment review, the hospice would be looking at an overpayment demand. These differ from those conditions of participation, which are ultimately all of the other very specific hospice requirements, such as those nursing facility contracting requirements. Those you're going to ultimately end up finding yourself with survey citations. If they're left uncorrected, there is the possibility for termination of the Medicare provider agreement or license. But in terms of those low-hanging fruit, the things that we need hospices to hyper-focus on a daily basis, it is those conditions of payment. And with the passage of the final rule, there is, if the hospice were to discover any of these coverage requirements may or may not have been met, there is that need to conduct that 60-day repayment analysis pursuant to that False Claims Act. So the key takeaways here with the coverage requirements is that they can arise in a lot of different scenarios. We see these quite often. For example, if a nurse is discovered to not be documenting or possibly not conducting visits, we also have quite recently dealt with a lot of potentially unlicensed nursing issues, and where that's going to implicate is really with the cross-reference to 418.56 as the plan of care issues. We also see hospices conducting pre-billing audits where it finds physician face-to-faces have not been timely completed. That's a certification requirement. You're looking at benefit period, potential repayment issues there. It's the way these conditions of payment are laid out is they just touch on so many different areas, and so while it might seem narrow, like, oh, this is just an election form, or oh, this is just a hospice certification, there are so many micro elements that are easy to miss there. So what do you do with this information? The biggest thing we see, or the biggest thing we really talk to our clients about, is making sure that really everyone is trained on these coverage requirements that could possibly come into contact with a scenario. Handout 2, and we call this one of our right-hand drawer handouts, list 10 questions that we think every hospice employee should be able to answer, and this will come into play also when we discuss the audits. But the key here is for these conditions to be met, and for people to understand the significance of all these micro elements on a, for example, certification form or the election form, they really need to know how they play into the bigger picture. For example, question 4, who determines if a patient is appropriate or eligible for hospice, seems to be a quite simple answer, that should be the physician. We so often see that answered wrongly, especially in the audit and on-site audit interview process. And so this tool is kind of a good threshold point for evaluating, really, are your employees in the know on this? Anyone that's going to have contact or overlap with these election or certification or even those plan of care requirements. Testing their understanding, you could do self-tests, you could have a consultant, a hospice-specific consultant in there that can help narrow out the issues, provide background information, and then test 30 to 60 days down the line. There's a number of different ways, but cannot emphasize enough how significantly important these conditions or coverage requirements are. Moving on to relatedness determinations, I think the key here, and why I think it's something I wanted to draw out for this audience in particular, is really the potential for things to be misbilled. I know Heather touched on this briefly, but hospices dating all the way back to 1983 are required to cover virtually all services. This was re-emphasized in the Hospice Wage Index in 2014. They again referenced this virtually all services requirement, and it's become a key enforcement area. As I mentioned, and we'll go into more detail, that APT report identified approximately $1 billion that were paid to providers outside of that hospice per diem. This 2012 OIG report on the Part D drug payment, we're just now starting to deal with settlements for hospices out of that, where they have had to settle with the Part D plans in terms of essentially coming to terms with money that the hospice really should not have been paid for drug claims that were also billed to Medicare Part D. And CMS, kind of with all of this, they did a series of guidance that came out around this issue, really expects hospices now to be reporting more than one diagnosis on the claim form to get into that terminal illness and related conditions aspect, and then to abide by that. If you're reporting something as related, you're covering everything related to that as well. So this kind of simplified buckets, for example, I think it's a pretty basic flow chart, but can provide a good background in terms of how CMS is kind of expecting hospices to work through this framework. I'm not going to go through it in detail, but I think the next few slides will help kind of provide additional information for moving through this flow chart. The expectations, like I said, is that hospices are going to be making these determinations. They're going to tie it to how they're identifying things on the claim form. I think the overarching point is physician involvement, and as I mentioned, they've already been trying to emphasize this with all of these changes dating back to 2008, 2009 in terms of tying in more physician involvement with the election, with the certification. They're also wanting that emphasis in terms of these relatedness determinations. So when you're looking at kind of a micro, your own hospice level, how is the physician involved in making these determinations? And then really the next big step, how are they documenting anything that is either determined to be related, but more importantly, how are they documenting or proving unrelatedness, where we are looking at a situation that something is going to be billed outside of that hospice per diem. And then there's kind of keys in terms of key drug types that they do expect to be most common end-of-life drugs. They're really expecting those not to be billed outside of that hospice benefit. And then, as we've mentioned a number of times, the diagnoses reported, those are going to not only directly correlate with the drugs that are reported, but they're going to potentially use those to look outside of that if anything else is being billed to other areas of Medicare. So the process that we kind of just general framework, it's really that a determination needs to be made. We've emphasized this needs to be the physician. And really the default arena right now is that items and services are related, and anything that's being determined unrelated is on a case-by-case basis. It is, as I said, the physician-driven decision, but also can, for example, with drugs, consider the role of your pharmacy benefit manager or any sort of pharmacy consultant relationship. And then consider using some high-level reviews to check with consistency among your key physicians that are involved in these determinations. What is the standard for relatedness? It's really kind of flipping it on its head and looking at it from the unrelated perspective. CMS has said it's clear evidence that an item or service is completely unrelated. And what that means is there's really no argument that could be made that that service or item could be related to the terminal illness or any of those related conditions that are identified. Then last or finally, how is this being documented and supported? We like to see proof that the physician is making that determination, and some sort of narrative explanation would be preferable over any sort of simple conclusory statement, this is related. You want to have the background there as to what was their thought process, how did they get to this determination. We've seen or heard that some hospices are using a standardized form that's helping probe or prompt that reasoning, getting them to kind of move through a process, and then any additional clinical support, especially if it's something a bit more nuanced, physician could be looking to journal articles as additional information to support that determination. And the issues, it seems straightforward, like that you would have this internal process, these issues wouldn't arise. But I think that's the issues are happening, or the root cause is really that there are so many different vendors or facilities that hospices come into contact with, that it's really a lot to manage in terms of making sure those vendors, those nursing homes, those even others within your own hospital system are not billing outside of that hospice benefit. I know we've had to change quite a bit of our contract language to insert clauses in there about making sure our vendors are checking with us specifically before billing anything outside, and then also on our own responsibility side, making sure the hospice is confirming that those things are unrelated, truly unrelated. It's just an additional safeguard that we're wanting to enforce here to make sure that this doesn't continue to happen and the hospices aren't finding themselves under even more scrutiny in the future. So getting to this claims data and government data analysis, I'm going to move through this somewhat quickly just because it's a lot of background data essentially and information that the hospice is going to benefit from narrowing down to their very entity-specific data and digging through that and kind of coming up with what we call a dashboard. As we've said, they're no longer limiting this data to length of stay or abnormal billing patterns such as, this hospice is billing a lot of continuous care, this hospice is billing a lot of general inpatient care. They really have gone quite broad in terms of what they're looking for. And we think that hospices, and we're really encouraging hospices to expand their dashboards in terms of capturing the same, or at least predominantly the same data that the government is looking at and analyzing. This APS report, it probably sound like a broken record with regard to mentioning this, but it truly is a large key of what led to payment reform and how that payment reform was structured. There's a lot of data in there, in large part that touches on what we just discussed with regard to relatedness. They found, like I said, nearly or over $1 billion that was billed outside of the hospice benefit. They really tie that to coverage decisions. They also touch on the hospice cap, live discharges, hospice utilization at death, general inpatient care utilization, continuous home care utilization, just to name kind of a few of those key areas. I'm not going to go through all of those here, but I think this one slide with regard to the relatedness determinations really shows where this money has the potential to be kind of inappropriately billed outside of that per diem. You can see in large part DME, money was going to home health. So inpatient services, that's referring to like inpatient hospital services that are not at that general inpatient level of care. They're truly outside of the hospice benefit. Part B, any sort of physician or outpatient services. The second largest here, Part D, which they really hyper-focused on over the past few years, SNF benefits, and just it sort of just paints this picture of where all this money was going and why the government is so concerned about those relatedness determinations that we just discussed. And really, what they've kind of described it as is hospice is cost-shifting, expensive care to other government payers. We don't necessarily think many of that or much of that is purposeful, but it gives that perception to the government that is what hospices are doing. Just kind of also looking at the live discharges, I pulled this information as an example because I think it's directly in part related to hospitalizations following hospice live discharges, and when we have hospital-based hospices, I think there's even more of a potential risk for this. So they have this pattern of they're either being discharged from hospice or revoking the hospice benefit, ending up finding themselves in an inpatient hospital stay, and then once that stay is done, separately billed to Medicare, re-electing hospice and rejoining that hospice benefit. That is truly one of the things they have pinpointed as that kind of cost shifting, and they're seeing hospices as cost shifting to having that expensive inpatient treatment billed to Medicare separately outside of the per diem. And they've really narrowed that in as an area of concern. So I did want to point that out, just because I think that's even at a higher risk when you have the hospice already embedded within that hospital setting. So the questions, I think, some of these lists have already identified them, but I think the app report in general provides a background of these other issues or items or data points that you could put on your internal dashboard. How many diagnoses are reported on the claims on average, how are relatedness determinations being made, coverage of drugs versus other items, visits prior to death, what are the number there on average, and then that GIP and continuous care utilization. Just while it is not new, it does continue to be an area that the government does scrutinize quite heavily. So we talk about risk areas and hospice audits, and I would say since I started with Reinhardt, my personal practice has really predominantly shifted to this area. I don't think there's a day that goes by that I don't spend some amount of time working on a hospice audit, whether it's helping with responding to a record request, strategy related to that, to actually dealing with all the different levels of appeal, which is quite backlogged right now. We have cases I started on almost 5 years ago that are just now creeping up to the ALJ level. So not only are these potentially significant in terms of dollar values, but they're also time consuming in terms of it's not a one and done. It's not something you can be done with quickly unless an entity is willing to just pay it off. But with the False Claims Act now, there's also an additional risk there in terms of potentially admissions associated with that. So what are we really seeing in the hospice audit arena? Still a lot of MIC cases. Those are those Medicaid integrity contractor cases. These are quite often occurring on a state-by-state basis. So for example, back in the spring, kind of in the March, April area, we had a large number of hospices in North Carolina all getting MIC audited the same week. And there's kind of no rhyme or reason to it. I think it ended up being some of the potentially larger or higher Medicaid billing hospices, but still really no rhyme or reason other than it was, North Carolina was the focus. That's what they were. It was North Carolina Medicaid was at issue, and the hospices that were billing there. I think 75% of those did happen with on-site visits and interviews, and we'll kind of touch on this, but we see commonly the same or similar set of questions, and they're not just interviewing, the most knowledgeable person. They could, interview a random CNA or certified nursing assistant. They could interview your chaplain, who, while might be the nicest person involved with that hospice entity, might be the least knowledgeable and really could be to detriment if they're not providing answers that suggest they have any awareness of what is going on within the hospice. We also continue to see ZPICs, so Zone Program Integrity Contractors. The big thing we're seeing there is they're starting to do some on-site visits. They can be unannounced. We might have hospice clients find out about these ZPIC auditors sniffing around because they might get a call from a patient or a patient's family that was interviewed. With regard to ZPICs, we kind of see the ebb and flow in terms of whether those results are extrapolated. What I mean by that is when they might take a sample of, for example, 30 patients and the claim, couple months claims associated with each of those 30 patients. They review them, they come up with a denial rate. They then extrapolate that denial result across all of the claims billed by that hospice for a 4-year period. And that's where we start to see these, what someone might perceive as a simple hospice audit turn into, $24, $25 million overpayment demands that then result in having to do these escalated appeals in order to avoid the immediate recoupment of those funds. And so and I'm not saying that to kind of paint a scary picture or scare anyone, but it is what we are seeing. And a lot of it connects back to that low-hanging fruit in terms of those technical requirements, and then what I haven't discussed in great detail is the ease at which these auditors can disagree with clinical eligibility. Lastly, we did start seeing RACs, the recovery audit contractors, again in the spring of this year, but we have not seen much impact from those. They've been really quite minimal. So for now, the predominant issues in terms of audits are those ZPIC and MIC auditors. As I mentioned, they're looking at clinical eligibility always. They will hyper-focus on those higher levels of care because there's a greater level of payment that comes with those, so GIP and continuous care. We've also seen their requests extend more often now beyond just the clinical records to business records. They'll request contracts with facilities and physicians. They'll ask for organizational charts, information on ownership, policies related to anything from admissions to discharges to how determinations are made with regard to different levels of care. So just another kind of important thing to keep in mind in terms of hospice operations is really those things need to be in order, and the ability to provide them on anywhere from 10 to 30 days notice. So with the on-site, since we are seeing a lot of that both in the MIC and the ZPIC realm, one of the tools that we've developed is handout 3. This is something that is kind of morphed, but it's kind of a basic checklist in terms of these hospice audit interviews and what in the MIC world what they'll refer to as entrance conferences. And it's just, I'm not going to go through it, but it really describes these kind of action items and then an explanation for why that might be something the hospice really wants to consider. One example in there would be, making sure to understand the question. It seems really simple, but kind of a big key is, listening to that question fully. We don't, going down to the next bullet, satisfying the questioner. We don't want to be over responsive to questions. We want to provide accurate information, but really truly be responsive with what we know, not try to kind of guess or impress with additional information. I think that's just, it's the second one of our right-hand drawer tools, something just really important to keep in mind, have on hand in case these on-site audits come. And it does play hand in hand with the second one I referenced earlier, these 10 questions every hospice employee should be able to answer commonly with these on-site audits, especially on the MIC side of things. We'll see them produce a staff list. They'll request very specific people with, and it's not necessarily the administrator who would probably be the most knowledgeable. It's usually a fairly random list of people with different levels of involvement, and unfortunately we find when we have a note taker in there that each of these people are responding quite differently to what should be pretty core questions that they should all be knowledgeable on. I think these documents, just as a kind of additional background, can also be used as somewhat of a test or a, a process to work through with employees or different people that are working closely with your hospice. Another area to just kind of keep in mind is this final handout 4. These are really, this is dated. It's from 1999, but interestingly enough, so many of the issues or risk areas identified on here by the Federal Office of the Inspector General still stand today in terms of being prominent issues in the hospice world. So I think this is just, again, kind of background to be aware of any potential issues, to also know what they have considered to be risk areas. Then, as we've mentioned before, being aware of the dashboard, how that compares to the APT report, lengths of stay, prior denials, potentially from additional development requests or from other audits. There's also fairly recently, and the name of it is escaping me right now, but it's a quite significant spreadsheet of data was released by CMS that is based specifically on claims data, so data that hospices are entering on their claims. And the breadth of this spreadsheet in terms of what it involves by a specific hospice to hospice, entity to entity basis is pretty incredible. I think it's a tool we're now talking to our clients about in terms of looking at that. It shows quite simply you can sort these columns of data and find out really quickly who's an outlier and by how much are you an outlier. Do you fall in the middle of the pack? Do you fall in the top 10? It can just be sorted so quickly to look at all of these different areas. It's also another tool to check in terms of claims data and how that's being reported. If any of that's inaccurate, it's also painting an inaccurate picture of your hospice entity to the government. And just as easily as we're sorting that data, so are they in terms of looking at who is an outlier. So I just wanted to point that out, and I'd be happy to send that spreadsheet around if anyone wants to email me directly. I know we kind of keep a copy of it ready on hand to send to people if they're interested in seeing where they lay. It can also be found on the CMS Hospice website. So in terms of the False Claims Act activity, there is a lot out there. I'm not going to go into the specifics of any of these cases. I know there's a lot of big kind of hot ones out there right now, but I think I just want to paint this broad picture of what's going on, not get into the weeds of any of the specific cases. The important background fact is that these have been increasing steadily each year. We're seeing more and more involvement of the government in these cases, and more also just individual whistleblower cases coming up through the pipeline. Again, not saying it is kind of a scare tactic, but just something to be aware of. And also with regard to whistleblowers, there's a lot of turnover in hospice, and just to kind of be aware and be attuned to what these employees are saying, if they have kind of internal complaints, taking all of them quite seriously, because one of the kind of #1 backgrounds or reasons for some of these whistleblower cases is when these disgruntled employees do not feel like they're being heard or that their concerns are being taken seriously. That's something we've been addressing more and more lately, and kind of helping hospices launch these internal investigations to help explore these areas, help these employees feel like their concerns are being heard internally. Just a kind of a slight sidebar there. As expected, this increase in False Claims Act activity is directly related to the growth in hospice, also related in some way to government incentives. We've seen this kind of return on investment for the government creep up year by year. Right now it's a little over $8 for every dollar that they're spending on these all this enforcement area. They're also steadily recovering more and more each year, so there continues to be the incentive to go after the hospice industry. What is a false claim? I'm sure most of you know that out there, but this slide provides the brief background. I think important points without reading it word for word is an anti-kickback violation is a per se violation of the False Claims Act. kind of the reverse false claim, they're not returning an identified overpayment within that 60 days of identification is another really critical area, and where I feel like we're spending quite a bit of our time these days. The typical basis for a Hospice False Claims Act case is commonly we see eligibility based, so the allegation that patients do not have that 6-month prognosis, and then one or more of these plus factors or plus allegations. And so we've kind of have a neat little diagram here that identifies a bunch of these different plus factors. And then on to the next slide, I won't read through each of these individually, but I think it's important to see kind of how these play out in terms of examples of those plus factors. Most of these have been pulled directly from actual complaints where these things have been alleged by either whistleblowers or the government. For example, under the eligibility documentation, that staff or personnel were coached to use creative documentation or records to support eligibility. And we've seen that not only with just general hospice eligibility, but eligibility for those different levels of care. Coverage requirements are pretty basic in the sense that those are, there's a lot of those hyper-technical items. But for example, one thing that we've seen is, the lack of a physician narrative, or more recently, at least in audit denials, which I think could extend, if it was highlighted by the right party, these really, really weak physician narratives. That's an issue we've seen on the rise. Are those actually really meeting those coverage requirements? Other examples with regard to the admissions and discharge practices, not involving all IDT members or especially the physician in either discharge or eligibility evaluations. Incentive comp is kind of always a risky area where we've seen a variety of different items been highlighted, but one example would be bonuses that are based on long length of stay, or even just really any length of stay, because these patients, should be admitted with that 6-month prognosis in mind. They kind of extend on through marketing, beneficiary inducements. Won't read through all of these very specific examples, but they're incredibly important to be aware of. And again, these are just a few of the examples of each different plus factor that we have seen and drawn out of these different cases. And so how are resources and energy spent in these risk areas? I think it stems back to some of the basics in terms of training on documentation. Again, one of the examples was, training for this creative or painting the picture type documentation. And I think it's important to know that that could be misinterpreted. I think we've seen, we obviously, when we work on these audit appeals or when we work with our clients and helping them draft these clinical response summaries, we do want them to paint the picture of the patient, but it is the true picture of the patient based on that documentation. We don't want, additional facts or any sort of fluffing going on there to make this patient seem more eligible than they really were. The coverage requirements, cannot kind of emphasize those enough in terms of those being the low-hanging fruit that the government is, can go after in these cases, but can really be the basis of a lot of these big audit issues as well. For example, getting down to the nitty-gritty of the election form, there are so many sub-requirements there. Most recently, the addition of naming the attending physician, but we've also seen concerns about specific language being included on there about the acknowledgement by the patient that they have chosen that specific attending physician. That also extends to the certification and very, very specific language to be included there, specific locations of that language. Admissions and discharge policies, I think, are low-hanging fruit in terms of the fact that admissions policies in particular can be closely scrutinized. Are they really truly spelling out this 6-month prognosis? Are patients really being educated there on not only their eligibility, but what they are waiving in terms of electing the hospice benefit? And then moving through kind of training on the compliance regarding these the anti-kickback statute, and that really gets into more of the contracting side of things, and then beneficiary inducement with bringing these patients on, in kind of big overarching areas that we did not get into the specific of, but incentive comp and marketing. We almost always see these coming up in some way or another in terms of these False Claims Act cases. And then kind of pulling it all together in terms of all these different areas discussed. We can't emphasize enough the dashboard, in really knowing truly where your hospice falls within all these different risk areas. As I mentioned, there's that APT report, the personal or very hospice-specific PEPR reports, and then this new spreadsheet of data that has come out that helps hospices really narrow down and figure out where they fall within the different risk areas, and then help them track for kind of future, if they've implemented any sort of changes, they can kind of continue to see in the years and months to come where they align. So I'm going to turn it back over to Heather so that she can kind of put it all together and provide her kind of more hospital-focused perspective here. And yes, I just want to thank you guys again for letting me be here with you today, and I hope you found this very helpful.
Carla, that was just excellent. Thank you so very much. In terms of next steps, okay, what next? And I think that it can be a little overwhelming when you sit through one of these presentations to understand just how multifaceted the risk presented by hospice can be. It really is something that is its own unique set of laws and requirements. And I think the first step I would suggest all of you do is start the conversation. You have an excellent presentation outlined here with lots of thought-provoking facts and figures and some very useful handouts. I would encourage all of you to take these handouts back to your hospice team and your compliance team. I think that sometimes just the simplest questions can get the conversation started. Obviously, there's lots of demands on resources, and compliance resources in particular are stretched thin. And hospice is really a key and a critical component of your post-acute care strategy for our health system. At the same time, I think we see that it's an often overlooked area of risk for health and hospital systems, and I think that it's really, truly important that you start the conversation so that you don't have the proverbial tail wagging the dog. So I think that the very first thing is to retrench yourself, re-educate, and train both your hospice staff, but also your compliance team, your billing staff, your medical staff. If you don't have knowledgeable people that really understand the hospice requirements outside of just the core hospice group, you're going to miss opportunities to engage in effective monitoring and prevention of issues. So as I mentioned, we have these tools to help you start the conversation, but what's really critically important is that you break down the silo between the hospice folks and the rest of your compliance program. In particular, I want to draw your attention to the concerns that Carla mentioned about Part B billing for hospice patients, and make sure that your billers and your coders on the physician side of things really understand the hospice relatedness determination, and that it's really important that they be able to flag certain issues or claims to ensure that they get the proper level of review so that you don't have unknowingly improper billing. I think secondly, I would say that it's really critical for your compliance officer and your internal audit teams to review your current audit and monitoring plans to ensure that you're addressing some of these specific hospice issues and risks. Do you have hospice as a component of your compliance dashboard capturing some of this key data that Carla has highlighted? Are you tracking your discharge and readmission rates, your level of GIP? Are you an outlier in terms of the number of hospice patients that are receiving GIP services? Do you have longer lengths of stay for your hospice patients? That's something that's going to flag you to these auditors. Do you have a means to review eligibility determinations, to review your documentation? Do you have continued really supportive documentation for the continued clinical eligibility of hospice patients. It's an ironic thing, but sometimes folks do better once they start receiving hospice services. It's really critical that you're continually evaluating the appropriateness of hospice services, as well as the level of care that you're providing to those patients. I think that the compliance committee itself probably needs to have an opportunity to see where you lie as compared to that APTS report that Carla mentioned to you, because it's an incredible tool and it is available and it is being used by the government. So I think it would be really, really important for you to take back to your organization the question of, what are we doing this? Is it on our dashboard? Could it be added? Should it be added? And I would caution again that oftentimes resources are prioritized on the basis of revenue generation when you look across the entire spectrum of services and care that you're providing. And this is one area where I think that the measure of risk maybe isn't always reflected by the total percentage of revenues that your hospice might be driving today. I also would point out that, as you're seeing, as Carla mentioned, there's a tremendous growth in hospice admissions and the number of patients who are seeking hospice services. So it's really critically important that you're evaluating those patients carefully, both for eligibility, but you make sure from the start that that election process is well done. I guess the third thing I would say that's an immediate to do is to make sure, for those of you who are legal counsel on the team, that you've addressed the low-hanging fruit with your hospice team, that you've reviewed your election form. You know, when they changed the form requirements to identify the attending physician, it's not just that you list a name there, but you also need support and language that shows that it was the patient's choice. And acknowledges that the patient has selected that attending physician. Carla emphasized for you, and I just want to hit home again, that the election form is the threshold to all the payments that you are receiving for hospice services. And so while I think many people would say, oh, it's a simple one-page form, or there really isn't always the scrutiny that should be applied to that really important piece of documentation. It's a really simple thing that you don't want to miss. I would also encourage you to review your hospice agreements. Those are really scrutinized by the government. You know, it's very interesting for those of you who are compliance officers on the phone and attended, you know, the National HCCA conference. This hospice was top of the list for the OIG, and they made a point of that at that national conference. And one of the key things they're looking at are financial arrangements hospices have with referral sources. I think that last but not least, I think that it's really, really critical that you ensure that you have applied resources to your hospice compliance that are match the level of risk you're willing to bear. Oftentimes people you know, just want the, is it being taken care of, and they accept the yes answer. But when you delve in deeper, you see that they believe and want to be at a, you know, X level of risk, but they haven't put in the operational resources and supports that are needed to make sure that you keep that risk to that level. And so oftentimes people have much higher risk exposure than they have a tolerance for, or really knowledge that they have undertaken. And so again, really important that you have those important conversations with operations folks, as well as compliance and financial services billing staff, to make sure that you are minding some of those gaps you might have currently in your compliance systems for hospice risk. With that, I think we are almost at our time, 12:59. I want to thank everyone for attending today. We have one question on the webinar if you want to. Oh, we have one question, and Carla is going to read that for us.
Sure. And so the question is, how are hospital-based hospices treated differently in terms of Medicare and or Medicaid audits? And I think that's kind of an interesting question in the sense that they're really not treated differently. There might be different outlier areas. For example, that hospice might have been, hospital-based hospice might have been targeted if it seemed to have had a high level of general inpatient care stays, potentially directly related to those stays being in that hospital, but really they're not treated any differently. They're going to be audited as a kind of independent provider, and they're going to be scrutinized just the same as any other hospice. And so I think that all of these keys where we've gotten really hospice specific in terms of the data to be analyzing and the preparation for those audits, the questions to know, they really are not different at all when you're a hospital-based hospice, other than that there just might be potentially a broader level of personnel that might need to know these items in terms of the overlap with the hospital for those general inpatient care stays. But otherwise, they're really treated quite the same. I think with time ending here, we will get back to you guys personally with any other questions that might be in the queue. So again, thank you so much for joining us, and we hope you have a great rest of your day.